Welcome, everyone. Thank you for being here during a very busy World Health Assembly week. My name is Herb Band. I'm the Executive Director of Access Accelerated, which is a co-founder of the Financing Accelerator Network for NCDs, the FAN. I hope that's your new favorite acronym. I'm also serving as chair of the steering committee of the Coalition for Access to NCD Medicines and Products. It's a privilege to welcome everyone here today. And we're really here with a very important topic and a shared focus, which is how can we help countries improve their health financing, particularly for NCDs and mental health, as part of universal health coverage with a strong focus on primary health care. We're really here today to listen to country needs and priorities and to celebrate their success. And I think that's something that's really important in these challenging times, that we recognize and celebrate successes at a country level. We're especially pleased to have with us here today ministers of health and their government representatives. We have the Honorable Dr. Haji Adam Abu Bakr, the Minister of Health and Human Services from the Federal Republic of Somalia. So welcome. Sorry, he's, well, okay, we'll send him an email. That's fine. Okay, thank you. We also have the Honorable Yudelka Batista, who's the Vice Minister for Strengthening and Development of the Health Sector from the Dominican Republic. Bienvenida. Your presence here today reflects really how central this issue has become for countries and the importance of partners working together. Thank you very much for being with us. And we strongly believe in the power of collaboration. And in that spirit, I'd like to recognize and thank our co-hosts for today's event, including the FAN, the PATH, the Coalition for Access to NCD Medicines and Products, and our Access Accelerated members, Sanofi Global Health Unit and UCB. Thank you very much. I would recognize we have many Access Accelerated members here today, and I'm very pleased about that. We have colleagues from BMS. Our other members are Chugai, Daiichi Sankyo, Lilly, Menarini, Novo Nordisk, Ono Pharma, Sanofi, Takeda, and UCB. So thank you very much. These companies really make our work possible. And finally, I'd like to acknowledge the NCD Alliance, who's not here today, I don't believe. They're running an event at the same time, but I wanted you to know that we coordinate. We talk to them all the time. We would each like to be at each other's events, so we decided to share our concept notes and our schemes. And so they're with us here today in spirit as we are with them, and we continue working together with them because it's such an important topic, health financing. There's so much to do. We can't do it alone. We need to collaborate. We have a full program today with great speakers. We'll take questions at the end in a dedicated Q&A session, and we'll open up the floor. But we have a lot of really good speakers, so we'll try to get through to everybody. And so I'd ask you to save your questions to the end. And then my final comment is we're very proud to have here today with us Monique Vletter from the World Bank Group. We've been working with the World Bank since 2017. And together, we work together with Results for Development to co-create the FAN. We started in Sub-Saharan Africa. We're now working in Latin America and the Caribbean, and we hope to expand to Asia Pacific. I'm extremely pleased and impressed and proud by the way the World Bank has stepped up its efforts on health financing, particularly for NCDs and mental health. And Monique will tell you about that. She's a key leader. You know she has a very important position in the World Bank, and we're thrilled to have you here today. Thank you, Monique.
But maybe just to say that at the World Bank, we are big fans of the FAN. We think it really represents the way we want to move forward, building local capacity, exchanges, creating opportunities for countries to exchange on what's really impactful, and then helping also in terms of our financing to scale that up. And so I'm really delighted to be here today. And we were just talking this morning with Access Accelerated and a group of the partners that next year we will have 10 years of partnership between the World Bank and Access Accelerated. And so we have to do a big celebration, and it warrants some champagne, but I also think it's just amazing to look back at those 10 years and see what we've done together. At the point when we started, we were mostly financing primary healthcare at the World Bank, focused on maternal and child health and nutrition. And while that is still very central and important, we were also slow in recognizing how disease burdens were changing. And the collaboration we started in 2017 with Access Accelerated really helped us to create opportunities for teams to work closely together with their ministerial counterparts in country to pilot new approaches, to really expand the package of services to include non-communicable diseases, but also to look at other aspects of the NCD agenda, including the really tough part around the pricing of pharmaceuticals and the fact that 80% of out-of-pocket payments is due to out-of-pocket expenses for pharmaceuticals related to non-communicable diseases. So including in terms of our poverty focus, it has become very much central in the approach of the World Bank. We recently announced a new goal to reach 1.5 billion people with access to quality and affordable services. We are at 575 million as of today. And I'm really happy to say that a large part of the financing commitments that were made after the announcement in 2024, roughly $14 billion in IDA and IBRD financing, about $6 billion of that is related to NCD expenses. And so it really has become, also due to our partnership, a really important part of our financing, and it's growing every year. So maybe just to end by saying that this is a huge agenda. There's not one organization that can do that alone. We're incredibly happy with the partnership with Access Accelerated. It's really important to our technical work, to the frontiers of our agenda in terms of local manufacturing, pricing of drugs, as well as the delivery of quality services in primary healthcare, which is so much part of our new strategic plan and objectives. So we very much look forward to thinking carefully about what will the next phase of our partnership with Access Accelerated look like. Thank you very much, and hope you have a very good conversation.
Thank you very much, Monique. Especially in the middle of a busy week, we're very happy to have you here. I'll now turn to our partner and our co-host, Dr. Kimberly Green, Director of Global Programs for Primary Healthcare at PATH and a leader of the Coalition for Access to NCD Medicines and Products, to share a few words. Kim.
Yeah, thank you.
Sorry.
Thank you. Tried to wedge in and out of this space. Yeah, so welcome all. As Herb mentioned, I work for PATH, and PATH is very fortunate to host the Coalition for Access to NCD Medicines and Products. Many of you here in this room are members. You'll know that this is a multi-sectoral group represented by governments, private sector NGOs, philanthropy, academics, civil society, and is working collectively across several countries and globally to increase access to essential NCD medicines and products. So, the Coalition recently was very excited with its 30-plus members to welcome a new member, the Somalian Ministry of Health, last year at our annual conference in Uganda. And so it's a real delight and pleasure for me to be able to welcome the Honorable Dr. Ali Haji Adam Abubakar, who is the Minister of Health and Human Services in Somalia, who will be providing a keynote for us today. Minister Abubakar is a distinguished physician and public health leader who has led major reforms across primary health care, universal health coverage, and national health sector transformation across the country. Since 2022, he has guided critical reforms in health financing, service delivery, and health systems resilience. And under his leadership, Somalia has advanced some very important national initiatives, which I'm sure you'll be hearing more about, including the establishment of the National Medicine and Drug Regulatory Authority, has helped to drive the NCD agenda by integrating the PEN package as part of primary health care, and has created an overall multi-sectoral NCD platform through which organizations and localities can coordinate. So with that, it is my absolute honor and pleasure to welcome Minister Abubakar. Welcome.
Thank you so much. And Excellencies, distinguished delegates, development partners, colleagues, ladies and gentlemen, it is an honor to join you during the 79th World Health Assembly and to participate in this important dialogue on financing non-communicable disease for impact. Somalia highly appreciates platforms such as this side event that continue to place sustainable financing for non-communicable diseases at the center of the global health agenda. Across many fragile and low-resource settings, non-communicable diseases are no longer future challenge. They are present reality, placing increasing pressure on households, health systems, and national economics. For Somalia, the challenge is particularly complex as we continue to front communicable diseases, humanitarian crisis, displacement, climate-related shocks, and growing burden of chronic diseases. In this context, financing non-communicable diseases is not only health priority, but also development and economic priority. Somalia believes that sustainable non-communicable disease financing must strengthen resilient and integrated health systems capable of delivering prevention, early diagnosis, treatment, rehabilitation, and long-term care in an equitable and people-centered manner. As we move toward the 2030 Sustainable Development Goals, Somalia is prioritizing stronger domestic resource mobilization, innovative financing approaches, and integration of non-communicable disease services into primary health care and universal health coverage reforms. We are also strengthening community engagement by involving people with lived experience, community health workers, women leaders, and civil society organizations in building more inclusive and responsive health systems. Recognizing that financing remains a major barrier to effective non-communicable disease response, Somalia is developing national financing framework to mobilize sustainable resources for non-communicable disease prevention and control. Current efforts include exploring taxation on harmful practices, strengthening health financing reforms, and integrating non-communicable disease priorities within broader universal health coverage efforts. Somalia is also prioritizing financial protection mechanisms that reduce barriers to accessing essential non-communicable disease services, particularly for vulnerable populations and people affected by crisis and displacement. Somalia firmly believes that sustainable non-communicable disease financing must support integrated health systems rather than fragmented vertical programs. We are embedding non-communicable disease services within the essential package of health services while strengthening implementation capacity across federal and state levels. Our national goal is to increase primary health care facilities providing non-communicable disease services from approximately 29% today to more than 90% by 2030, particularly in rural and underserved communities. By bringing services closer to communities, we can reduce late diagnosis, prevent complications, and lower long-term health system costs. As an important pillar of this effort is the expansion of WHO-banned interventions within primary healthcare systems, alongside training healthcare workers to strengthen early diagnosis, referral systems, and long-term management of chronic diseases. Somalia recognizes that health systems alone cannot address the growing burden of non-communicable diseases. For this reason, we are developing multi-sectoral national NCD strategy for 2026-2030, addressing major risk factors including tobacco use, unhealthy diets, physical inactivity, and air pollution. Prevention remains central to sustainable financing and long-term population health outcomes. We are also integrating non-communicable disease considerations into emergency preparedness and humanitarian response planning to ensure continuity of care during crisis. Somalia deeply value collaboration with WHO, the World Bank, Access Accelerated, the Coalition for Access to Non-Communicable Disease Medicine and Products, and other partners supporting innovative approaches to financing and equitable access to non-communicable disease services. Excellencies, distinguished guests, as we look toward 2030, financing for non-communicable disease must become an integral component of universal health coverage, primary health care strengthening, and broader development financing. Fragile and low-income countries like Somalia must not be left behind in the global non-communicable disease response. Somalia remains committed to translating political commitments into measurable action through stronger financing systems, integrated health services, community engagement, and multi-sectoral collaboration. The challenge before us is significant, but meaningful progress is possible when political commitment, evidence, partnerships, and sustainable financing come together. Thank you very much.
Thank you, Honorable Minister, for your keynote address. Very inspiring. And it's impressive to see the progress you're making in Somalia. We're pleased that you'll remain with us as long as you can for the ministerial panel discussion. So next, I would like to invite John Ferris, who's head of the Global Health Unit at Sanofi and a recently rejoined member of Access Accelerated, to share a few remarks and help facilitate the panel discussion. John.
So thank you, Herb, and this is the first time I've ever done this in a garden, so hopefully it works out okay. I think the weather's been kind to us. So I think this is a very distinguished group of friends, I would say, and partners, and I think this partnership piece is what's really crucial to me. All of us have the same mission on the NCD pandemic. We have, in a sense, that we're all trying to manage, but coming together as partnership with ministries, with NGOs, with other companies and the private sector and organisations like yourself, Herb, are crucial to make this happen. And we started our Global Health Unit about 4 years ago now, and we picked 40 countries across the world where we thought we could make a difference. And these 40 countries were selected because of their NCD burden and their future NCD burden, but also because they have underdeveloped healthcare systems. So people either had very little access or no access to healthcare. And because of the work we do collectively, we've been able to create 120 projects now across the 40 countries. We've reached 6 million beneficiaries. We have launched a portfolio of impact products, to your point about pricing of medicines, in the NCD space, including insulins, which interestingly has been a real success. We've trained over 40,000 healthcare professionals to help deliver healthcare at a community level many of the times to make a difference. And I think this shows what can be done as partnerships. We've also invested about $11 million in startup companies that are part of the ecosystem. So we can do this, and we can do it together, and it's important that we do it together, but we need the sustainable financing piece that goes with it. Because all this work is for nothing if we cannot create an environment where this is taken forward. And I have to congratulate the ministries that we work with, and some of the ministries are in this room today, because this starts with a strategic plan together on what the target is, how you're going to do what you're going to do, what you need to achieve, but more importantly, how you're going to take this work forward afterwards, and how we're going to continue to be there for patients and measure and monitor what we do. So congratulations to everyone in this room for how far we've come, but we've literally hit the tip of the iceberg. We've got so much still to do, and these dialogues are really important, these events are really important, and the reason we're working with Herb and his group again is because we see the progress that we're making. And for me, the finance agenda this year is top of the agenda. And I look forward to a great dialogue with the panelists now. And Herb, I'm trying to keep within my 3 minutes because I can see him glaring at me, so we'll need to get a move on. So I'm going to ask my panelists to do exactly the same in a moment. So I'm going to ask to come to the stage here. And our keynote speaker, the the Honourable Minister, I think you set this up really, really well, and thank you for your points, because this is going to help really the dialogue for moving forward. So thank you for your input. And I know that, you're one of the countries we work with, and it's a pleasure to have you here, and thank you for your time. So firstly, and I had a lesson on how to pronounce your first name, so I'm probably going to get this wrong. I have to invite the Honourable Udelka Batista, is okay? Not too bad. Who is the Vice Minister for Strengthening Health and Development from the Dominican Republic. Please, can you join me here? I got that wrong, right? You did it well. Okay, did it well, that's fine, yeah. I'd also like to invite Dr. Gerald Muntingi, who is Head of NCD Prevention and Control at the Ministry of Health of Uganda. Welcome. And the final distinguished panel guest is Dr. Hamdi Mohammed Osman, who is Head of National NCD Section of the Ministry of Health and Human Services in Somalia. Welcome. And as you can see, we've really got. I'm going to move here because it's very rude to stand behind there. I hope this works. So welcome everybody. We're really pleased to have such a distinguished group, and I think from the opening speech and everything we've been discussing, this is a really amazing group to talk about what we want to cover today. And you have 4 minutes each. I'm just warning you, okay? Because Herb will probably get very aggressive behind us if we don't do this right. So let me turn to you first, please, Vice Minister Batista, okay? So NCDs in the Dominican Republic account for about 70 to 75% of deaths, which is, I think, probably common across the geographies we're talking about. And this puts huge pressure on your healthcare system and the finance system in general. So what are you thinking about in terms of handling finance differently? What are you looking at in terms of, balancing domestic resources? And how can you get external support for development banks, for example?
Thank you for your question. The first thing I want to say, thanks, better. Thank you. Buenos días, buenas tardes. Voy a hablar en español porque para mí es mucho más fácil comunicarme en lenguaje técnico en español. But I want to say thanks to the fund members for this invitation. Es cierto, la República Dominicana tiene actualmente un 70% de las muertes.
This is the mental agility test of the session today for me. So I'm going to try to translate, and my native speakers will correct me. But it is true that the Dominican Republic has a major NCD burden, 70% of mortality.
Lo cual nosotros consideramos que es una crisis que es sanitaria, que no solamente afecta la salud de nuestra gente, sino que es un riesgo bastante alto para la productividad de nuestro país.
So we're really in Dominican Republic, it's a health crisis that affects not just the health of the population, but also the economic situation of the country.
Por supuesto, afecta nuestra distribución del presupuesto y mayormente esto ha sido porque a través de todos los años se ha concentrado el presupuesto en tratar las enfermedades crónicas no transmisibles. Hospitalización, la dotación de los medicamentos, y nunca vimos la importancia de la prevención.
So this crisis affects the budget distribution in the country, and over the years the budget has really started to focus on NCDs, but focusing more on treatment at the later stage, so hospitalization and other costs associated with treating sick people, and not focusing enough on prevention.
Políticamente también nosotros identificamos que el gasto de bolsillo para nuestras personas también es significativamente alto y que también se empobrecía, es un motor de empobrecimiento las enfermedades crónicas no transmisibles, sobre todo para aquellas personas más vulnerables. Y lo que es lamentable es que enfermedades largas como el cáncer, hemos visto cómo familias de clase media se han visto afectadas y bajan un quintil de pobreza. Es decir, se hacen más pobres.
So this is particularly important because the out-of-pocket expenditure for people is significantly high, and this leads to poverty, especially for vulnerable populations. And we see this particularly with longer-term illnesses like cancer, which have a huge economic impact on people and their families.
En ese sentido, y es una decisión política que es impulsada incluso por el mismo presidente de la República y por supuesto por nuestro ministro, es que trabajemos en la prevención y en el diagnóstico a tiempo.
So this is a political decision made at the highest levels in the country by the president as well as the Minister of Health, and the focus is really on diagnosis, prevention and diagnosis.
¿Y cómo lo estamos haciendo? Actualmente tenemos 3 proyectos importantes de salud con financiamiento externo, con cooperación reembolsable, donde estamos abocados al fortalecimiento de la atención primaria. Cuando digo fortalecimiento de la atención primaria, es más que nuestro primer nivel de atención. Estamos hablando de unidades particulares que en nuestro país se llaman UNAP.
Se llaman, pardon?
Unidades de atención primaria.
Okay. So how is this being done? There are 3 principal projects. The first is around external co-financing, really focusing on strengthening primary health care. And so primary health care units are a key priority.
Okay.
Más o menos?
Algo así. Sí, algo así. Bueno, pero veo que muchos sí hablan español. Entonces, sí hay otros 2 ejes que, bueno, lo he mencionado. No solamente es el fortalecimiento de la atención primaria, dotando a nuestras unidades de atención primaria de las herramientas que nosotros les llamamos pequeñas, pero que son extremadamente necesarias. También nosotros estamos, abocados a también fortalecer las capacidades resolutivas del primer nivel de atención, pero en el médico de familia. Para que el médico de familia, la gente, nos hemos dado cuenta, nosotros como un país con zonas avanzadas, rurales y subrurales, la importancia de la comunicación médico-paciente.
Oh boy.
Okay.
So
Sorry.
the second pillar is really around strengthening the patient care, and the family doctor is really a key figure here because of their high touch points with the people.
Bien, entonces, visto esto, no puedo dejar de mencionar que también nosotros hemos identificado la necesidad de transformar nuestro sistema de salud a un sistema de salud digital.
We're also, as
Digitalizado.
a third priority is to transform the health system into a digital healthcare system.
Entonces, en resumen, nosotros estamos moviendo nuestros recursos de financiamiento externos para el fortalecimiento de la atención primaria y para eso, fortalecimiento de la atención primaria.
So in summary, really the key here is to move the external financing resources to strengthen the primary health care.
I hope we did well.
Okay,
Both.
good.
So, does this one work now? Yeah, it does. Congratulations to both of you. You looked happy with what he translated, so it sounds like it's okay. I think so. It's okay, good. No, but I think congratulations on the work you're doing. I particularly like your view on prevention at the very beginning here, and we stop people from getting more serious diseases. I think that is a massive burden that we underestimate at times. So
I think that another thing with this really important is that our ministry is cardiologist, and he has the vision about it, how important is the preparation, the diagnosis.
excellent. So thank you so much. So we're going to move to Uganda now, and we've done quite a lot of projects in Uganda, and I know how successful you've been in making progress around NCDs, but also universal healthcare reforms, which is not easy under a difficult financial system. Could you give us one lesson that from Uganda's experience that might help the other countries in this room and also the partners to understand on how we can truly make a difference?
Thank you very much, and Your Excellencies and distinguished delegates. In Uganda, we have now integrated NCDs into primary health care. Before we did that, we did a study to see whether we integrated management of hypertension and diabetes into HIV care would work. Because our HIV colleagues were concerned about the successes they have already achieved. And they thought integrating NCD care would compromise their successes, would bring stigma, and things would not work. So we first did a study, which is actually published in the peer-reviewed journals. We decided to open up HIV clinics for NCD care. So it didn't matter whether you have diabetes, hypertension, or HIV, it was the same clinic. And we thought people without HIV would fear, because of stigma, to be associated with HIV. But we found actually stigma was with us, the health workers. Because what the patients want is the quality health care. A case in point was TASO. TASO stands for the AIDS Support Organization. It has a big clinic in Kampala. And the people who go there are normally HIV. But when we said people with diabetes and hypertension, irrespective of whether you're HIV or not, you can go and get services. They were overwhelmed. People are interested in services, not where they get the services. So we learned that, and we decided now, with stop orders and reducing financing for healthcare, we have decided that we integrate chronic care. Whether everybody with a chronic condition will just go into that stop clinic and will get services. And the lesson is that patients will go there so long as the service is there and they don't have the stigma. So that is what we want to learn, and that's what we want to share. And the successes in HIV were not compromised at all. Still high patient turn-up. They were not lost to follow-up. Adherence was good, and the virus suppression remained very high. So what I advise our colleagues is that don't fear to integrate, thinking that the successes in other programs will be compromised by integration. We still do have challenges that I call upon the partners to partner with us, especially that people who are used to managing HIV, they are now finding it difficult to manage hypertension and diabetes. But we've tried to create simple protocols for them to follow, and they are trying. You say if you get this measure, you start on one drug. If after 1 month it is not improved, then increase the dose or add a drug. And they are doing it. But we need more of that training. Also, the other challenge is that the drugs for NCDs are in most cases out of stock, yet the drugs for HIV are available because of the partner support. So we still have a challenge of the supply chain, but also the challenge of healthcare workers prioritizing NCD drugs, medicines. Quite often they have a smaller budget, but they buy other things than NCD medicines, because NCD medicines are expensive and somebody will be there for long. So it eats much in their budget. So they would rather buy the other drugs. So we need to sensitize the healthcare workers. We need to improve the supply chain system, because there are also some weaknesses there, but also to orient health workers on how to manage NCDs. But otherwise, it's working, and it's work in progress. Thank you.
No, thank you very much, and I'm really glad you raised the point about the success of the work you've all done with HIV, because that model is something that, you know, we don't want to need to fix something that's not broken, and I think we can learn an awful lot. And I know some of the work we've done together has been around looking at how successful the HIV model was, and how do you adapt the training beyond that to NCDs, and then integrate that into the model, because there's a lot of good infrastructure there that we can already work on. I think your point about drug costs and supply chain is something we all struggle with, but it's something we have to fight and find the right way, because affordability is crucial, and continuation of supply. So very, very good points made. Thank you there. So finally, we'll move to Somalia. and thank you for being here. We heard the wonderful speech from your Honourable Minister, and your commitment to NCDs is very, very clear. And it's interesting that you're establishing an NCD registry, which I think is really important for long-term care and management of patients. So how will the data practically change what decisions you make from financing, and what becomes, what is possible after this registry that wasn't before? Two questions there, I'm afraid.
Thank you, and thank you, Excellencies and gentlemen. And as you know, what I'm thinking about Somali now, he was saying our Minister of Health, but I little bit in technical level. And NCD registry now is an important and component of Somalia responses in strengthening evidence system, national and data accelerator, and through in Financing Accelerator, and also in World Diabetic Foundation for the Development Indicators is having starting this year, and also the first time Somalia is developed NCD registry, and also indicator system integration in the DH2. And the bunch of geologists was faced a fragile setting and also limited available data in planning. But when it comes to Somalia, first registering, it was in a pilot, and it started for the Benadir region and Southwest state. And this registry, Somalia expected to come, and also important is in strengthening the data environment financing system. Registry expected support surveillance, investment in development. And for me, this is also committed budget advocacy integration into the priority national financing framework, universal health coverage strategies. In surveillance registry system will also improve in understanding system partners, service, and utilizing in continued care, well, a term treatment outcomes, and also as an essential development, sustainable and financing for module. And it's also supporting for our initiative for integration into the primary healthcare. And I hope it comes more and useful data and investment as the governance now is facing to multi-sectoral using in domestic and also in donor and partners supported. So the Somalia this time when was before facing so in CDC and this data and registry will support the Somalia to see how is the NCD increasing, what is the exactly burden of the Somalia NCD, and to allocate financing for in the governance. Thank you.
So thank you very much, and I think this is part of the journey here that we're all talking about is how do we measure the impact of the great work you're all doing, and I think it'll be wonderful to see how this registry goes forward, because everyone competes. The health ministry competes with the other ministries for financing, and I think proof points of data are important. But also for me, for NCDs, it's the adherence and the long-term care of patients that we need to manage. And the economic proof points after this are really, really crucial. So thank you very much. So I have a quick 2-minute answer from each of you. And Herb, you've got to be ready to go again here with your translation. Thank you to all of you. A quick question. It's a bit of a big question, and 2 minutes is not really long enough to answer it, but let's give it a try. So if we look ahead to the next 2 or 3 years and towards the 2030 Sustainable Development NCD targets, what is the one big thing, the one big shift that would make the biggest difference to how your NCDs are financed in your countries? So I'm going to start in the Dominican Republic, if that's okay.
Yeah, it is. I wrote a few things in English as soon as I knew that I have to speak in English. So
English is great.
I'm gonna try it.
Okay.
Okay, but be there.
Ella va a hablar
But
en
be there.
inglés.
Yeah.
So he's going to do Spanish in the background. It'll be perfect. Yeah? Your English is great.
Do you think so?
Yeah, it's perfect.
No. I don't, maybe technically, not that.
Technically,
not
go
that
for it.
good.
Yeah,
Okay,
you
I'ma
can do.
try
It's a
it.
double act.
Okay.
Yeah.
Okay, we have already 30 minutes
Yes.
joking, 30 seconds joking. Okay. To achieve the 2030 ODS, Objetivo de Desarrollo Sostenible, SDG, health target for NCDs we must transform the way we invest in health. Today, the system spends far more when people are already seriously ill on hospitalizations, surgeries, advanced complication that comes from diabetes and hypertension. The major shift must be toward invest in prevention and health outcomes through primary health care. In other words, resources must be direct toward ensuring that more people have controlled blood pressure, stable diabetes, and early diagnosis. Aquí tengo que hablar en español.
No, está bien.
Tenemos que cambiar el modelo y nuestro sistema de control de gestión. Y tenemos que movernos a un sistema de desempeño donde nosotros podamos medir el servicio de salud por pacientes controlados, por pacientes tamizados.
Pacientes camisados.
Tamizados.
Screen. Thank you very much. So we need to change the model for control here, moving the health system from patients controlled to patients screened.
Okay. Para nosotros es importante seguir avanzando la implementación de la estrategia HEARTS. For us, it's really important to go in to ampliar, to display the HEART strategy, and very close to the strategy is to give to the people the medicine.
Medicine. Yeah.
Is correct technically? Yeah. Para poder y dar la medicina que se requiere para que estén en control.
To give them the medicines they need to keep good control.
Digital transformation in particular will allow us to measure outcomes in real time and make better evidence-based decisions. No lo tienes que decir en español.
Perfecto.
We also need policies that promote healthier lifestyle and ensure that financing reaches the population and territories where it can generate the greatest social impact. In summary, the sustainability of the health system will not come from spending more once disease is already progressive, but from investing earlier in prevention, well-being, and healthy years of life.
Congratulations. Well done. So let's go to Uganda.
Thank you very much. I think she has answered on our behalf.
Bilingually as well, it's fantastic.
Yes, because we think investing in primary health care will make a difference, because we can't keep mopping the floor when the tap is not closed. We think we need to emphasize prevention, and we know the risk factors. I think if we tackle the risk factor through primary health care, we make a difference. And for us now, we've integrated NCDs into primary health care, emphasizing prevention and early diagnosis. That's why we have community health workers going from house to house, screening for at least hypertension and diabetes, and also giving some education talks on nutrition, on physical activity, on avoiding alcohol and tobacco. We think that can make a difference. And primary health care is funded by taxpayers' money, government, so it is sustainable, and partners will find us along the way. If people want to come and support us, they will support our strategies, which we have already started. But otherwise, the funding now is from government. It is inadequate, but we have started anyway. Thank you.
Thank you very much. And again, please, yeah. And again, I'll summarize at the end, but fantastic points. So finally, and most importantly as well, we still go back to Somalia, please, yeah?
And thank you. When Scab is in Uganda, I can say and I can't stand with him, because the countries we see that in the NCD registry, peer-to-peer is there, and Dr. Galati worked with us and very well, and thanks him. And also when it comes to NCD multi-sectoral and strategy initiatives, we see their strategy to up to Prime Minister and the community. we worked like the example countries in Somalia is taken. And thank you, and also this question very I'm seeing in the suitable and Somalia. Also, when it comes longer and fragile in low in country incomes in NCD, this question can address any NCD and also global financing package provided for the support the countries with a solution that match and scale for urgent in these challenges. And Somalia remains committed as our Minister of Health in collaborative and say it is also partners and strategic equitable resilience and people-centered for this sustainable response. The growing burden of SGD improves the health well-being of our community. This is in take is for Somalia, and thank you so much.
So thank you very much to all three of you. I think it's amazing to have three visionary people here that really know what the difference is to be made to help NCDs. And I wish some of your population could be here to hear you, because I think they'd be very proud of what you're trying to achieve. I think the shift to primary healthcare, the way you talk about it, and the prevention and the whole patient journey is what is crucial here. And we have to keep fighting for the financing to make it happen. But I know with you three leading this, everyone has a great chance. And congratulations in what you're doing. And thank you on behalf of everyone for you being here. And please give them a big round of applause. And I hand back to my bilingual moderator here. Thanks, Herb.
Thank you, John. Bang on time, too. Thank you very much, distinguished speakers, and John, for a stimulating panel discussion. Another thing to remember from today, we can't keep mopping the floor when the water tap is not closed. So thank you, Dr. Matungi, for that. The minister needs to leave for another meeting, but we appreciate him and the Somali team being here. Thank you very much. So since we're in Geneva, it goes without saying that another organization that is working hard to improve health financing at a country level is the World Health Organization. So I'd like to introduce Dr. Dan Chisholm, who's a health systems advisor for the WHO, and he'll offer his perspectives and experiences on closing the gap for financing for NCDs and mental health conditions. Dr. Chisholm.
Thank you very much, Herb. Great to be here. Good afternoon to all, and what should I say? Buenos dias, mais aussi bon appétit. Very happy to be joining this discussion and add a WHO perspective. As many of you know, WHO's functions range from development of technical norms, standards, guidelines, through to country support. But I'll be focusing my remarks on another function, which is more around the global leadership, coordination, and partnerships. Because I want to talk about the international dialogues of late on sustainable financing for NCDs and also mental health. So I thought the easiest way to do that is just to break it down by year, 2024, 25, and 2026. So Monique didn't mention it, but just to set the scene, back in 2024, the World Bank and WHO co-hosted an international dialogue on this topic. Many of you we have followed that and been actually there as well. And I think it's worth reflecting on some of the key messages or insights that came out of that dialogue and what that has led to. So the first one, I think crucially, a message that came out very clearly is that despite the tectonic shifts that we've seen in the development sector in the last year, and also despite the very challenging macro-fiscal environment that countries are operating under, I think a key message was that to be genuinely, truly sustainable, the financing response has to be ultimately led domestically. And the role of external financing is complementary rather than replacing that core responsibility and function for domestic investment. A second one is around the ability or the lack of ability of many health systems to cater well to the needs of people with long-term conditions, NCDs, mental health conditions, other chronic diseases. And so I think, we discussed a lot in that meeting how health financing strategies and mechanisms can actually be used to leverage some of the primary healthcare and UHC reforms in countries through better strategic purchasing, obviously fiscal policies, including health taxes, and so on. And basically try to use health financing mechanisms to incentivize as well some of the changes that we need to see across countries and develop more integrated models of care. And then the third and final one, of course, is around financial protection. So we all know how, as we've been discussed already, how very burdensome the conditions can be on household budgets. And so I think a clear message, and particularly when you look at the evidence around how much of the out-of-pocket spending is related to medications and how much of and that is related to NCD conditions. So that very much points to the need for targeted support and targeted efforts to expand financial protection and also address the price and access to essential medicines. So that's 2024. 2025, many of those messages, those insights, but others as well, of course, made their way into the preparatory stages for the high-level meeting on NCDs and mental health last year. And I think that has led to, one, showing the political declaration basically very clearly shows the centrality of health financing for advancing the NCD agenda. And of course, we also have now a global target around financial coverage policies. At least 60% of countries having explicit financial coverage policies covering essential NCD and mental health services and products. So that's fantastic. And then for this year, 2026, the conversation continues. The Department of Health of the Philippines, who were very much champions at that second dialogue and in the run-up to the high-level meeting, are now going to be hosting another dialogue on sustainable financing in a bit later at the end of the summer in September. So I think it's a great timing in the sense that it's coming less than a year after all these commitments and targets were set. So to really discuss how countries can deliver on these commitments. So there's a big focus on the implementation, very much the how we can do this, operationalize sustainable financing reforms. And there'll be also the timing is interesting, specifically because of some of the GLP-1 drugs coming off patent in 2026. So this is a specific kind of deep dive that the Philippines and ourselves, will be trying to hold during this dialogue, so that we can explore what the implications of that can be in terms of making those medicines more accessible, more affordable. So there's like three, apart from the usual country exchange and learnings, there's three expected outputs from this upcoming dialogue. The first one is very practical, a kind of sustainable financing toolkit, dare I say, another one. No, but this is meant to be like a very concise, almost like an aide memoir in French, you'd say. I don't know what the English phrase would be, but it's to help NCD program managers and other stakeholders navigate what can be a very complicated landscape, the financing landscape and all the different issues. So it's meant to be a very, almost like a sort of checklist to help people navigate that. A second important part is a planned regional compact to strengthen, aimed at strengthening access to medicines, including some of those GLP-1 drugs. And then the third one would be more like a political declaration, a Manila declaration, call to action, etc. So that's the plan at the moment. We will see if we will make it to Manila. Of course, as you know, Philippines, like many other countries, are suffering a huge evolving energy crisis. And it may be that the meeting moves online, but for now we are planning for an online in-person meeting by invitation from the Department of Health. I think the Secretary has been busy issuing invitations over the course of this week. But in the meantime, there will also, we're planning a multi-stakeholder briefing, probably at the beginning of July, so watch that space, where we'll be looking for get more details about the planned event, plus get inputs and feedback on some of those outputs that I mentioned. So I think that's what I wanted to say. Thank you very much. And as Herb mentioned, there is another. Exactly, it's very ironic timing. Well, there is another event taking place, so I am going to run to that. But I see Rodrigo and also Bianca from our Department of NCDs and Mental Health are here, so they may be able to address any other questions. So thanks so much.
Thank you very much, Dan, Dr. Chisholm. We now move to a panel discussion exploring the evolving landscape of NCD financing in Latin America and the Caribbean, alongside findings from a country survey that's being conducted on NCD financing priorities. And just some context, we were working on a landscaping survey of NCD financing in Africa about 2 years ago, and we learned that our friends from PATH were doing a similar study. So old way of thinking was, we're going to move fast and we're going to beat PATH and we're going to publish first. New way of thinking is, why don't we join forces and work together, and we can have a much greater impact. So I thank Kim Green for that collaborative spirit. But I'd like to invite our partner, Agnes Munua, who's a program director for Results for Development, to moderate this discussion.
All right. Good afternoon. My name is Agnes, and I'm from warm and sunny Nairobi. So if my voice is shaking, it's because I'm terribly cold. Yes, so forgive me. I'm getting used to it. Okay, another statement I learned this week: I stand on established protocols. And so just that I don't get anything wrong. Thank you very much for having me here. And today we have two wonderful panelists who are going to share some key messages from the study that Herb mentioned from the Latin American Caribbean region, and Dr. Kimberly Green also sharing work that they've done on the Coalition for Access to NCD Medicines and Products, hosted by PATH. So I'm going to invite Professor Federico Agostino as I give a short bio, right? So up front, we already have Dr. Kimberly Green, who's the Director of Primary Healthcare from PATH. And then we have Professor Federico, who's the Director of the Department of Health Technology, Assessment and Health Economics of the International Clinical Effectiveness and Health Policy Institute from Argentina, IX. Yes. So without taking any further time, I'm going to ask that you go ahead to share your key messages from your studies. I'm sure everyone's very keen to hear what's happening in the countries and how they're organizing their financing and pooling, arranging those funds that are collected and also used to deliver services. So over to you, Dr. Kimberly.
Thanks so much for the excellent introduction, and thanks so much for the framing, Herb, as well. So yeah, as Herb mentioned, we, with the high-level meeting last year, the coalition was really thinking about how best to generate greater insight on the lived realities of countries when it comes to financing NCDs as part of universal health coverage. And similarly, the Access Accelerated through the FAN was thinking about, was doing the same. And so it was a really wonderful moment of convergence to align forces and look at how we could collectively generate more information. I think, how many of you feel like it's easy to track NCD financing across low and middle income countries? Raise your hand. Oh, okay, we had someone. So I think for us, we took a cross-section of countries through the coalition that have different experiences in terms of financing to get a sense of what the limits are, where we might have outliers and what the median might be. So we included 7 countries across Asia, Africa, Latin America, the majority in Africa. And so that was Kenya, Ghana, Mozambique, DRC, Rwanda, Peru, and Vietnam. So very different settings, and some countries that have done quite a lot already in terms of national health insurance, domestic financing. and have made quite a lot of advancements even in the last year since we've done the survey. One caveat here is this survey was looking at resources allocated for NCDs, how efficiencies were created, and then visibility and accountability, the ability to track resources, not only in the government, but for civil society. So this survey was done around March through July of last year. And what do you think was happening around that time? So major shift in global health financing. Yeah, so there was the stop work order, and at the same time also other ODA was declining. And so we have, I think, a really interesting cross-section of time in terms of allocation of resources to NCDs. But I would just say that obviously it's representative of that time in these countries and not where we are right now. So I do think collectively it's very useful for us to do some follow-up engagements with countries to see how they've pivoted, adapted, and shifted. But at that time, what we found is that across those 7 countries, none of them felt that they had optimal resourcing for NCDs. They felt it was low to medium of what it should be. And at the same time, they had underscored worries about allocation, the current allocations, which were not where they needed to be, being shifted because of the constraints on needing to fill gaps for HIV, TB, malaria, other health areas that were being funded by external donors. So that was really the sort of the critical baseline that we found. And then, we saw, of course, and we know this, the total financing for NCDs where that was available, it was really a blend across donors and donations of specific medicines, also from the private sector and from the public sector. There was only one country, Rwanda, who were able to secure 67% of their resources domestically for NCDs. All of the other countries were reliant more on other sources of funding than through domestic financing. And so we also looked then at health taxes. And no surprise, 6 out of 7 countries had health taxes for tobacco, but much fewer for sugary beverages and for alcohol. So I think this tells us there's opportunities for support for countries to be able to transform the reforms for tobacco and tobacco taxation to a more broad taxation policy. However, some of the countries flagged that they measured that only 35% of the resources that were meant to be allocated for health were being allocated for health. And again, we know that this is a lived reality of many countries. For efficiencies, as Gerald described, one key driver of efficiency is integration. Integration is no longer optional. That's what all the countries said. They were rapidly driving, even very quickly because of the stop work order, even faster acceleration of integration, trying to find ways to bring HIV, TB, malaria, NCDs all together. And Gerald provided an excellent example of that. But also better purchasing power for medicines. Trying to see how they could get better pricing, align across pooled procurement, but not yet with some strong strategies on how to find better pricing for NCD medicines and products. In terms of visibility and accountability, there are 2 countries that had a specific accounting process for NCDs through their national health accounts. And so that was great to see, but that that should be standard really everywhere. All countries should be able to track their allocations for health, whatever it might be for, including for NCDs. So that's a very rapid summary of what we saw. There's a one-pager available, I think, somewhere here on a table, I hope. So let me know if you're interested, and otherwise we'll share that with you electronically. Thanks.
Thank you, Dr. Kimberly. And we'll have the general Q&A. We'll be able to fill them. We'll move to Professor Federico, who will give us an overview of the key trends from the number of countries he was able to look at in Latin America and Caribbean region.
Thank you, Agnes. My pleasure to be here. I can speak in Spanish or English. What do you prefer?
Where's her?
Okay.
We've lost the translator.
So, let me start with a simple observation. In Latin America and the Caribbean, we don't have a lack of ideas on how to finance NCDs. The real challenge is how these ideas are organized, sustained, and scaled. I think it's the same music that you found in the 7 worldwide countries, no? our regional analysis shows a structural mismatch. NCDs represent about 2 out of 3 deaths and ill health in our region, and yet financing systems are not designed to support long-term prevention or continuous care. Our work was not just a research exercise. We deep dived into more than 150 papers and documents. We interviewed 22 key stakeholders from LAC, and then all the findings were validated through a regional dialogue with 45 stakeholders of more than 10 countries. And the issue is not only how much we spend on NCDs, on how little do we spend, but how financing is structured, coordinated, and more importantly, translated into care. In many cases, we are also trying to finance chronic disease using systems that are focusing on acute or infectious diseases. What was particularly strong in our regional dialogue, and there was a coincidence in governments, industry, civil society, technical partners, and multilateral organizations, is that there was an agreement that one of the key barriers in the region is the fragmentation, the contrary to integration that you was mentioning just a while ago. That's the key barrier to progress. And fragmentation operates at multiple levels, across financing streams, across programs and initiatives, across data and health information systems. For example, in our preparatory survey, more than 80% of respondents said that fragmentation is the top barrier that we have in the region. And one important thing is that countries do not lack solutions. They lack the ability to connect them, to synergize them. A second critical issue is what we call a data paradox. We are asking countries to make better decisions, to make better financing decisions, but in many cases, they often lack basic visibility on how much is spent in, for example, in LAC, there are very few countries who know how much it is spent in NCDs and where these resources go, and significantly, what outcomes do they generate in the population. So without visibility, we cannot prioritize. And without prioritizing, we cannot advance in any NCD reform. We also saw a very important opportunity. The region has already many of the solutions, many of the things already built in. We have health taxes almost in every country, mostly focusing on tobacco, strategic purchasing mechanism, integrated care models, and data systems. The challenge is that they remain isolated, unevenly distributed, and difficult to scale. So we do not need more pilot projects. We need to stop reinventing solutions and start to scale and connect solutions that are already in the field. One thing that countries told us very clearly is that they do not want more technical assistance or isolated technical assistance. They are asking for better data and traceability, stronger tools for decision-making, support to scale existing programs, and more structured regional learning and coordination. In short, they are asking for support that helps them move from projects to systems. And this is where FAN, or the Financing Accelerator Network, that you also have a one-pager in your tables, can play a critical role. By helping make financing more visible, connecting countries facing similar challenges, and supporting catalytic initiatives that can scale. The Financing Accelerator Network of NCDs is not about introducing new ideas, but it's about helping countries organize, connect, and scale what already exists. So if we want to make more progress, I would say, in NCDs. The question is no longer what should we do, but how we make it work, scale in a sustainably and equitable way.
Thank you very much.
I don't know if I used my 7 minutes. I could. Your Swiss watch?
Yes. I think I have time for one follow-up question for both of you to answer. So something I had that's coming up quite strongly. We talk about evidence-based decision-making and the rhetoric around we need data and evidence, but we're not able to track to even know how much we're spending. It's very hard to make an informed decision. How much more, how much less? Where do we prioritize those resources and allocate them? So my question to you, you talked about NHAs, but what mechanisms can countries put in place to improve visibility? Just that first step of making sure they are aware of how much is being allocated to NCDs and how it's being used and who it's reaching.
Yeah, I mean, I think we see countries using where they're successful at tracking data on NCDs, and I can name some other countries like Indonesia and increasingly Vietnam. They're linking data that they're pulling from their national health insurance schemes. So like prescription data, diagnoses data, so being able to pull that and align that then with the funding flows and allocations through national health accounts. So these are tried and true systems. They're being applied in many countries. For Indonesia, they're now looking at applying AI to be able to also pull insights related to financing, not only for NCDs, but across the board. This is important for them and also for Vietnam because they now have a national screening program for NCDs, which is new, and they don't have the financial tracking systems in place yet, but it's a critical component to promoting health promotion and prevention and management of NCDs. So I think those are some great examples to look at. And so all to say, we don't need to reinvent anything magical. I think there's great tools out there that can be applied.
Thank you.
Well, yes, I think that many of the components of the strategies are already there. Some examples in the country, in our region, for example, Jamaica has a national health fund that uses part of the tobacco taxes to invest in NCDs. Dominican Republic, that was just recently there and explained how NCDs are being tracked more. But one problem that we have in the region is that in many countries we don't have a national health insurance. No, so we have social security sector, private sectors, public sector. So each subsector collects data, but there is a lot of difficulty integrating data from all sectors and building up to national health accounts or national data.
And you're right, fragmentation of data systems is a big challenge. And just to note, even those countries that have health insurance systems, it's not the only flow of funds, right? And so triangulating across these different data sources, be able to create the data that is needed by the decision makers. Definitely an area to continue evolving and getting better at. We don't have any more time, but there'll be a Q&A session later, so we welcome your questions at that time. Thank you very much, Dr. Kimberly, Professor Federico. You may take your seats.
Thank you. Thank you, Agnes, and thank you, Kim Green and Professor Augustovsky. On the screen, I think we're going to call up a QR code that has an executive summary of the FAN landscape study, if you want to download that. But there's also, for those of you who are still addicted to paper, like me, there are paper copies of some of the coalition work, as well as some of the FAN work, which you can pick up on your way out. I'd like to now turn to another interesting piece of work that's going on, and this is a comparative country analysis in sub-Saharan Africa. So I'd like to invite our friend Sana Frosthelt from the World Diabetes Foundation. She's the Director of Policy Programs and Partnerships to moderate this discussion. Sana.
Is it on? Yes. Thank you so much, Herb, and good afternoon, everybody. Agnes, you're not the only one who's cold. At least sitting out there, I was also a bit cold. The FAN the FAN have been undertaking a cross-country analysis that offers a look into how resources are raised, pooled, and used specifically for NCDs across 5 FAN member countries in sub-Saharan Africa. And today we have the chance to have an early look at some of the key themes emerging from that work. To help us unpack some of the key insights, I'm joined by Dr. Jackson Otieno of the African Institute for Development Policy. That's FAN's regional NCD Financing Accelerator in Sub-Saharan Africa. Dr. Otieno is a health economist with over 20 years experience across Africa, Asia, and North America, supporting countries and organizations in using data to inform policy and decision making. So welcome, Dr. Otieno.
Thank you.
And I think we only have, 10 minutes sharp for this conversation, so we'll try our level best to get through all the important work that you have to share with us today. So if we start with the good news from the study. When we look at the 3 core functions of health financing, so that's revenue, pooling, and strategic purchasing, where are FAN members making progress, particularly in terms of the new health financing approaches? And can you highlight, maybe in the light of time, just 1 or 2 of the most promising innovative initiatives emerging from the analysis that you've been undertaking?
Yeah, thank you so much. I also should mention that it is quite cold. I hope my brain is not freezing. Yeah, but having said that, yeah, I wish I had more time to talk about this. But let me first speak just to, and when you look at what is changing, picking it up from revenue or resource mobilization across the countries that FAN is working in, I could pick on Ghana. Ghana has a national health insurance levy, but before last year it wasn't capped. So that meant that when you're talking about earmarking, really it wasn't earmarking per se, because much of the money it's a 2.5% of VAT. So what that meant that the money was not specifically going towards the health. But now, since somewhere end of last year, the entire 2.5% is now coming to the National Health Insurance Scheme that can then now go towards certain interventions like NCDs. So looking at when you talk about revenue, domestic resource mobilization, I think that's a great example showing how countries are now committing resources. If you look at that in absolute terms, that is about 10 billion Rwanda, not Rwanda, but Ghana cedi. That's quite a lot of money if it goes to the National Health Insurance Scheme, and it is the biggest component of that scheme. And so if you look at the insurance coverage, which is about 54%, then the question we should then ask from a policy point is how do they translate these into financing NCD? That's another area. In terms of risk pooling or pooling generally, I could use the example of Kenya, where data show us that the reform process that they've had, where they have different funds, looking at the benefit package for oncology, which has just been enhanced to about $6,000 US. This amount of money, it is a bit more innovative, because if a patient exhausts that amount of money, they automatically get moved to a different funding bracket, where we have the emergency and critical fund. And then those long-term care can be undertaken using that fund. But then again, issues of NCDs, the government has in place a government-funded primary healthcare fund, which again has things around the NCDs in terms of screening, diagnosis, and all that through the government system at the lower level, level 2 and level 3. So these are things that are emerging. I could have talked about purchasing, but I can stop there.
Thank you so much. I think super interesting insights, and I think also bringing a lot of new knowledge to this agenda. If we turn to looking at a few of the common challenges that you find in that member countries, FAN member countries are encountering in this area, what are some of the key financing gaps or issues or patterns coming out of your study, if you were to highlight just one or two of those?
Yeah, the issue of data, my prior colleagues have talked about the issue of data. I must flag that as a big issue, data on NCDs. For example, you ask about financing for NCDs, get data, because data is important in decision making. I mean, each country has a different data around how much the government or how much is being actually spent on NCDs. Even within country, there are also differences in understanding of this data. So I think data is a big issue. We have talked about health taxes, and I think somebody has, one of the panelists before, we talked about the issue of health taxes. And indeed, Kimberly mentioned about 6 out of the 7 countries had health taxes. Apparently, the perception countries have around health taxes is not really a health financing perspective. It's more or less like a fiscal space kind of opportunity. So the resources are more or less looked at as you are helping the government generate resources. Where they headed, where they end up to may not necessarily be health. So that is something that we are seeing, that earmarking is really not co-moving with the health taxes. Right.
Good. Thank you so much. So the full study is not out yet. I understood from our conversation before sitting down here today that it'll come out over the summer.
Yes,
you
it
expect?
will. Yes, we expect to have it over the summer.
But if you were to leave policymakers with one or two sort of takeaways from the research that could guide decisions in the near term, what would that be?
So, as fun, I think one thing we are trying to make countries understand, or make our partners understand, is that the fiscal space where we are currently is not something that is up for discussion, like add more money to add more budgets to NCD and that kind of stuff, because many of the countries are really facing different macro fiscal space. I mean, there is the issues of debt. Quite a number of countries are under complete debt distress. Then there is the issue of how the country's economies are actually performing as it is right now for many other reasons. But we are saying that there are already resources on the table. How then do we discuss or help the ministries of finance and ministries of health allocate some of these resources towards NCDs? The easiest way would be to help these countries put evidence or the required evidence to justify reprioritization or integration, and this is where that all integration concept is coming in, so that NCDs has a space within the existing the processes, and more so at the primary care level. So that is one thing we are looking at as an opportunity. The other thing we are looking at as opportunity, there's a lot of conversation around the national health insurance or risk pooling now. From the AU at national level, everyone is talking about how do we come up with a great scheme for a national health insurance scheme, which is a good thing. And so then when they design their benefit packages, I think what countries should look at is how to integrate, again, the NCDs within those benefit packages. So we are not moving, we are not pushing these things out and kind of saying, let's put in place a new thing. No, we want to address the real problem, because it is NCDs which is the real problem. And as my colleague from Uganda used our African say, that you cannot continue mopping when the tap is doing what? running. So let's invest in stopping the tap from flowing. Right.
Thank you so much. I think this conversation could go on forever and ever, but I think all of us have places to be, places to run to. So thank you so much for the research and for coming here to share with us. Please, maybe everybody give a round of applause for Dr. Otieno. Thank you.
Thank you, Sana, and thank you, Jackson, for the first look at this interesting analysis. As Jackson said, it'll be available over the summer. So please look forward to that. So I'd like to apologize to our colleagues from Kenya about the temperature, and to you all. But when a lady from Denmark says she's cold, I start to get really worried. So I think in the interest of humanity, we're going to just have a very short Q&A session, and then we'll turn to the closing. So we did promise you a Q&A at the end, and I often follow up on my promises. So does anyone have any burning questions that any of the speakers can address? Well, maybe just one. All good?
Mine is super simple. Where can we get the research when in the summer when it becomes available?
Yes.
Where can we find it?
Yeah, so we have a fan website called ncdfinancing.org, and thanks to the good work of my colleague Tui, there's a knowledge hub there where everything we have gets published. So it's intended to be a one-stop shop with all the resources, the great work that's coming from YEX in Latin America, the work from AFIDEP. So please visit the site, and I hope the resources are useful to you. Yes, Ruth.
Thank you so much. Oh, okay, not loud enough. Thank you, everyone. It's been a really interesting and thought-provoking afternoon. Maybe this is a question for either AFIDEP or R4D, I'm not sure. I wonder if, just given, these discussions that we're all having about sustainability and sort of where the fan, really is providing evidence, right, in terms of supporting domestic resource mobilization. Are you able to give us a sense of, what you're hearing in terms of how the fan is supporting, the move towards, governments really seeing the, the evidence and that supports, putting more resources towards health services and seeing health as an investment and not, a budget line item per se. Thank you.
I'll start with that and then pass to Jackson. So the ultimate test of the fan is, are we genuinely helping countries to move forward? And that's something we're keenly focused on. And I would like to give a plug to this short two-pager is available on your way out. This is a case study from Kenya that looked at exactly that question. Are we moving the needle in Kenya? A lot of great work has been done in Kenya, and someone who's not here today who sends her regards is Dr. Gladwell Gatecha from the Kenyan Ministry of Health. She's been a true champion for our work. But I would invite you to look at this because this is some early evidence of the impact we're having in Kenya. And when I say we, I mean the whole collection, the whole community that's working on this. So take a look at this, but it's an excellent question. Jackson?
Yeah, I should say that one area where the fund works in is to provide the countries with the TA, technical support. And within countries, we have what we call the country core groups. That is the country core groups of fund. And what is interesting is that if you look at countries like Kenya, which have already received their seed grants, that is part of what fund does, to catalyze some of these initiatives, what they're asking for is evidence. Kenya is now building up, using the seed grant, an investment case, a framework for modeling an economic framework for modeling the investment cases. Why are they doing this? When they went to Parliament asking for more money, one of the things the parliamentarians told them is everybody is coming here asking for more money, but the most important thing is could you give us evidence that will show us that really if we put so much, then we are likely to address the bigger problem? Because we are saying, Let's stop looking at health as a social investment. Let's look at it as an economic imperative. And that is a kind of, now you see it is the Ministry of Health speaking with the Ministry of Finance and the Parliament. We are a bit out there, but we are supporting the entire thing at the background. So I think going forward, because this is demand-driven, it comes from them, they should be able to answer the bigger questions that is being asked in terms of resource prioritization or resource allocation towards health. And if you want to add something?
I was going to say that there is momentum on the continent right now, and I'll give example of Ghana. For example, Mahamacare, which is the new fund that's been put in place for NCD care and covering, catastrophic spending from households. Kenya with the chronic illness and emergency fund. So there are countries that are beginning to think of more holistically how to fund NCD care because of the impact to households. So I think it's building on that momentum, but I'm glad to say that we're not walking alone, and there are many actors who are also building this argument. And I think now we realize that health is not just sucking up funding, but also an imperative for economic development and a healthy population. So, having more advocates speak about it is very helpful. I was just going to say that Jackson used to work at the Ministry of Finance. So hearing someone from Ministry of Finance speak so positively is also very encouraging for the rest of us. Thanks.
Thank you very much. Yes, Matthew.
Thank you so much, Herb. So I hear a lot about, there's a lot of demand for evidence, for data, and we see that a lot in our work as well in oncology all the time. More evidence, more data, more evidence, more data. I want to ask the fan, how do you actually verify the asks for evidence? Because sometimes too much evidence is also polluting, and the need of, the data is not being utilized. People ask for report, ask for data, ask for evidence. They don't do anything about it. And creating evidence is a huge, huge resource investment, resource mobilization. And so I want to understand, how are you, is there a notion of arbitrage of where is it worth really generating the evidence? Which decisions or which demands are, reasonable, not reasonable? And knowing that I'm just coming back from a country that will not name, but most of the financing allocation decisions are political. And for example, allocating millions on ultrasound screening for breast cancer, while there is no scientific evidence at all that ultrasound screening is worse. Ultrasound is only for downstaging. And in the meantime, for very basic intervention and diagnostics, they ask for localized evidence. We need local evidence if this ultra-proven intervention is working in this context. So there are a lot of unreasonable, I would say, ask for evidence. I want to know if there is any thought on how to navigate that.
Thank you for your very easy to answer question. I can start. We have some experts in this room, but you're right. Everybody wants more evidence all the time. I think this is where our country core groups come in, and you know this model very well from City Cancer Challenge. By having a city executive committee or a country core group, we have a team of experts at a country level who I think prioritize what the needs are and debate amongst themselves. So I think there is a curation mechanism there, and our country core groups are generally led by Ministry of Health, but have links to Ministry of Finance and civil society and others. So before they come to the fan with a request, there's already been a debate about, is this our most pressing need? But you're right. The evidence is great if it leads to action and impact. And so far, with the fan fund grants that we've made, we've had a fairly rigorous vetting process. And this is something that Results for Development helps a lot with. Agnes has spent a lot of time on this, talking to the country groups to say, is this what you really need? And are you really going to use it? Because what we want to measure with a fan fund grant is, what does it lead to? This is supposed to be catalytic funding. It's only catalytic if it leads to something bigger and better down the line. So we're very mindful of that issue, and I think we have some mechanisms. I don't know if we have the perfect solution, but Kim.
Yeah, and I mean, this is probably not the answer that you want, but where I see data being used well is where there's a strong accountability in healthcare to the community and to the stakeholders that are part of healthcare. And so examples of this is where there are transparent dashboards that are shared collectively across district leaders, not for health, but overall leadership, with citizens groups, with healthcare workers to track performance gaps and to work together to solve for them. So that's increasingly being used, but only, I think, in places where there is already that culture of accountability and transparency. But what I can say is that I think collectively we, should, be sharing information about those experiences and that learning as a good way to go. And I can say, again, Indonesia is doing that, which is really fantastic. But also Ghana is now making a move with PHC-free to do the same thing, because PHC-free is meant to be accountable to citizens. And hopefully Ghana's not the same place where you saw the ultrasounds for breast cancer. Hopefully you can tell me later.
Okay, very good. Well, again, in the interest of time, I'd like to head to our closing. And for our closing, I'd like to invite our colleague Bruno Stendert. He's the head of health equity at UCB, which is a long-standing partner of Access Accelerated, and ask him to deliver some concluding remarks on behalf of all the co-hosts here today.
So, first of all, Herb, many thanks for organizing this. Thank you to all the speakers, the panelists, the moderators, the co-hosts, and all of you attending this nice meeting. It has been very rich, and really the discussion was engaging. We covered the last 2 hours a lot of things, but I will summarize it in 5 points, 5 things that I take home. The first one is progress is possible despite the environment that we live in. Constrained circumstances, competing global priorities, increased demands on health systems. The second thing that I could observe is leadership. Leadership from the countries themselves, Uganda, the Dominican Republic, and Somalia, alongside all the efforts of our hosts, and I name them, of course, Access Accelerated, but also FAN, PART, the Coalition for NCDs, Sanofi, UCB. There is really leadership to make this happen. The third thing is there is a clear willingness to move forward based on evidence, shaped by the local priorities and sustained through partnerships. We heard it today. There is not a lack of commitment or political will, quite the opposite. There is clearly a will to translate our ambition into impact, and that through financing systems that are coordinated and capable of supporting the local policies, programs, etc. Fun is fantastic. I am a fan of fun. But there is more. The initiative of fun really matters for NCD. And we need to take that as a key message home today. I'm very glad that you launched FAN as Access Accelerated with partners, so not on yourself, with partners, including the World Bank, Result for Development, IFIDEP, IX. It helps countries to strengthen the domestic financing, but not only by mobilizing additional resources, but also using existing resources more effectively and efficiently. Without sustainable financing, there is no healthcare delivery possible. There will be no access and no health equity. It is also important that we remind ourselves that at the center of all this are people, individuals, families, communities, whose lives and futures depend on the decision we take now. And they are at the center of this work. I really hope that from now in the future, as we did in the past, their experience must continue to shape what we do, our policies, investments, solutions, and partnerships. We need to listen to them. So, with that, I wish you a very, very nice afternoon, and let's stay engaged, continue learning from one another, strengthen partnerships, and move together from insight to commitment to implementation. Many thanks, Herb.
Thank you, Bruno, and thank you from my side to all our co-hosts, speakers, panelists, the delegation from Somalia. With that, we're going to give you 13 minutes back, which makes me a happy Swiss for the rest of the week. Thank you for being with us here, particularly to the end, and we wish you a very successful World Health Assembly week, and we look forward to seeing you at the next event. Thank you very much.